Welcome to EPG Pathshala on the subject Social Medicine and Community Health. I am Dr. Vidya-mitra, Professor in the Department of Community Medicine, Institute of Medical Sciences, Banaras University. I am here to discuss the module National Vector-Borne Disease Control Program and Overview and National Anti-Malaria Program. This module belongs to the paper National Health Programs and Policies. The module has been developed by a team comprising of myself, Dr. Taneja, Dr. Ramesh Verma from Rohtak and Dr. Banerjee from New Delhi. The learning objectives that has been set for this session is: number one, to enumerate strategies for prevention and care of vector-borne diseases under National Vector-Borne Disease Control Program. Number two, to state a strategic plan for malaria control in India in terms of vision, mission, national goals, targets, objectives and outcomes, as well as impact indicators, and identify linkages of strategic plan of malaria in India with regional strategy of WHO and Southeast Asia region. Mention categorize strategic intervention for achieving pre-elimination status and describe strategies and categories for the program. Mention broad malaria control activities, state objectives, norms, strategy and organization set up for urban malaria scheme, and give an overview of national drug policy on malaria. Vector-borne diseases are major public health problem in India. The National Vector-Borne Disease Control Program is an umbrella program on vector-borne diseases. And this program is an integral part of the National Health Mission. The National Vector-Borne Disease Control Program was integration of three ongoing centrally sponsored programs: National Anti-Malaria Program, National Malaria Control Program, and Kala-Jar Control Program, and converging prevention and control strategies of JE and dengue. Chikungunya re-emerged in the country and was also brought under purview of the Directorate National Vector-Borne Disease Control Program since 2006. The strategies that has been included for prevention and control of vector-borne diseases under National Vector-Borne Disease Control Program is: number one, integrated vector management, disease management, supportive interventions, capacity building initiatives, vaccination only for prevention of Japanese encephalitis, and annual mass drug administration only for filariasis. Out of these six diseases that have been included under National Vector-Borne Disease Control Program, all five are transmitted by mosquitoes. Only the Kala-Jar is transmitted by sandfly. And out of these two diseases, Kala-Jar and lymphatic filariasis has been considered for elimination by the year 2015. National Anti-Malaria Control Program. Malaria was a major public health problem in India. In the 1953, when the National Malaria Control Program was launched in the country, there were 75 million cases of malaria per year and 8 lakhs deaths. And now malaria, the number of have declined substantially, but there are other major issues that in malaria control. National Malaria Eradication Program was launched in 1958 based on the success of National Malaria Control Program strategies from 1953 to 1958. Urban Malaria Scheme was launched in 1971-72 and modified plan of operation was started in 1977. In fact, the tremendous success that was achieved during malaria eradication phase program could not be sustained for a longer period. And malaria re-emerged in our country in 1976 and modified plan of operation was brought in. Enhanced Malaria Control Project was started from 1997 to 2005. Then National Anti-Malaria Program was started in the year 1998, and this program was brought under the umbrella of the overall program of National Vector-Borne Disease Control Program in the year 2003 and 2004. And this malaria is caused by many parasites of Plasmodium species. Plasmodium vivax is responsible for 47.4% cases, Plasmodium falciparum 52.6%, and Plasmodium malariae rarely found in India, and Plasmodium ovale not found in India. Plasmodium novalsky, P. novalsky species recently found to be cause of malaria. National Vector-Borne Disease Control Program, Malaria is providing 100% central assistance to 7 northeastern regions, states. The strategic plan of malaria control in India 19 started from 2012 to 2017, a 5-year strategic plan has clear-cut laid down its vision. The Government of India's Vision 2022 has identified what are the goals that are to be achieved by 2025 in the context of malaria control. So vision, mission, national goals, targets and objectives, that is reducing annual parasite incidence less than 1 per thousand, outcome indicators and impact indicators have been well laid down in the strategic plan of India. Second, India's National Malaria Strategic Plan 2012-2017 is in the line with a number of broad categories of regional malaria strategies of WHO and Sero region. In fact, whatever strategies they have decided for early detection of cases, prompt treatment, and emergency response, and so on, has been incorporated in this. Categorized strategic interventions for achieving pre-emergency state has been decided. The Technical Advisory Committee for the program has approved the 3 categories with a specific broad strategies depending on whether the state has API less than 1, all districts have less than 1 API, then the state as a whole has API less than 1, but some districts have API more than 1, and state as a whole has API, annual parasite incidence more than 1 per thousand population. So Technical Advisory Group of India has worked out clear-cut guidelines and strategies, and the details are given regarding National Malaria Strategic Plan, categorized strategic National Technical Advisory Committee recommendations in the module. Broad malaria control strategies have been laid down, and 6 personal protective measures have been also included in the program. Now, broad malaria control activities are basically classified into 3 categories: epidemiological surveillance and disease management 1, number 2, integrated vector management, and number 3, supportive interventions. The first category, epidemiological surveillance and disease management, early case detection by further strengthening existing surveillance system and involving private providers. Why private providers? Because many of the patients in our country go to the private sector for day-to-day consultations. Then strengthening of referral services and epidemic preparedness and rapid response. So these 3 major activities are included in the epidemiological surveillance and disease management. Now, whenever a person reports fever, slides are taken, and then that is put to a microscopic examination. Insecticide-treated nets, long-lasting insecticide-treated have been introduced in the program for personal protection and to interrupt transmission. These are the mosquito nets that are in use, and that is the major strategy. Insecticide-treated nets, ITN, long-lasting insecticide-treated net, LLIN, are the major instrument for preventing malaria in many areas in the country. Now, personal protective measures preventing mosquitoes from entering the house. To prevent their entry, all the doors and windows should be kept closed during 5 p.m. to 10 p.m. in the evening and 5 a.m. to 7 a.m. in the morning. Protection from mosquito bite, protecting clothing, wearing light-colored long pants and short-sleeve shirts. Mosquito repellents. There are 2 types of mosquito repellents. One is natural repellents and another is chemical repellents. Natural repellents are essential. Oil extracts from plant, citronella oil, lemongrass oil, and neem oil. Chemical repellents, heat, that is the N-N-diethyl N-polyamide and permethrin integrated in the cloth. So repellent sticks are available, mosquito repellent mats are available. Insecticide vaporizers types are, that is the mosquito coils, vaporizing mats, and liquid vaporizers are and aerosols. Most of these products contain synthetic pyrethroids like DL3 and D-trans-L3. They are commonly being used in urban areas and to take indoor facilities. Now, insecticide vaporizers are commonly used in urban areas, and liquid vaporizers that are quite common. Mosquito nets, as I've said earlier, they are the best and safest. Insecticide-treated bed nets have emerged as a very important tool in malaria control in endemic areas. But air conditioning is a highly effective means of keeping the mosquito away, other insects out of the room. Indoor residual sprays for adult mosquitoes, chemical control. For indoor residual sprays, insecticides in the use are DDT 50% wet powder, Malaria 25% wet powder, and synthetic pyrethroid like Deltamethrin 2.5% wet powder, cyclothrin 10% wet powder, and lambda cyhalothrin 10%. So there are many chemical compounds that are advocated for indoor residual spray. The DDT 50% wet powder, preparation of suspension in water 1 kg per 10 liter. It gives the doses per square meter of active ingredient is 1 gram per square meter. Residual effects last for 10 to 12 weeks. Area to be covered by 10 liter of suspension to get correct doses 500 square meter. Malathion, that is the organophosphorus compound, 25% wet powder, 2 kg is mixed in 10 liter. It gives a dose of 2 gram per square meter of active ingredient. Residual effect lasts for 6 to 8 weeks, and area to generally covered is to 250 square meter. Deltamethrin 2.5% wet powder, 400 gram per 10 liter. 20 milligram is the per square meter the active ingredient. Residual spray effects last for 10 to 12 weeks, and 500 square meter is to cover area to be covered by 10 liters of suspension to get correct dose. Cyclothrin 10% weight powder. The preparation is 125 gram per 10 liter. 25 milligram is the dose per square meter of active ingredient, and residual effect lasts for 10 to 12 weeks. And again, 500 square meter can be obtained by 10 liters. Insecticide spray operations. The indoor residual spray of human dwellings is important for malaria control. In the revised approach to malaria control, it has been decided to spray human dwellings and mixed dwellings. But cattle sets are not to be sprayed because that will save insecticide, and also after spraying most of the mosquitoes, they go to the inside the dwelling places, that is inside. Planning for survey operations. The planning of spray operations will be done by district malaria officer. Under the modified plan of operation, the spray operations are to be carried out according to annual parasiting incidents. However, the priority of spraying will be given to high-risk areas, API more than 2. Spray activity, techniques and operations. Spray squads are there, gangs are there. One squad consists of one supervisor and 5 workers, that is Swasthya Sahayaka. Seasonal spray staff is recruited for spray activities. For every 5 workers, 2 stirrup pumps are, for every 3 persons, 2 hand compression pumps are provided. Output and coverage, 40 to 50 houses can be sprayed with 1 stirrup pump in a day, or 80 to 90 houses per squad per day. 12 pound of malathion, 25% used in 3 gallons of water. 1 gallon is required for one house for 2,000 square feet. So 3 gallons will cover about 6,000 square feet. Techniques of good spray depends upon discharge rate should be 740 to 850 ml per minute. Distance of between nozzle tip and wall should be 18 inches. 40 up and down strokes per minute to maintain the pressure. Movement of lance in such a way as to cover 2,000 square feet area, one house, in 5 minutes consuming 1 gallon suspension. A good quality spray should be led to uniform deposit on walls and other sprayable surfaces. Space sprays, these mosquitoes instantly kill the adult mosquitoes. These insecticides kill instantly the adult mosquitoes with no residual effect. Space sprays must be repeated on at least once every week. Space sprays, these insecticides instantly kill the adult mosquito with no residual effects. Space sprays must be repeated on at least once every week, and paraquats are commonly used for this purpose. Types of space sprays: thermal fox. Thermal fox can be oil-based or water-based or the oil diesel. Ultra-low volume, aerosol, cold fox and mist. It requires a small quantity, less than 4.6 liters per hectare. Vehicle-mounted fogging. This type of fogging can be used in urban and suburban areas. One machine can cover about 15 to 20 houses per day. Insecticide formulations for space sprays: organophosphate insecticides, malathion. For ultra-low volume spraying, 0.5 liters per hectare. For thermal fogging, 1 part technical solute grade is diluted to 24 parts of diesel. Then phenitropin, pyrimidine-phos-methyl, paraquats, permethrin, delta-methrin can be used for this purpose. Biological control using larvivorous fish. Biological larval control using larvivorous fish is feasible in certain ecotypes and settings and would be propagated in these areas as supportive interventions to control the breeding. The source of supply for larvivorous fish is supplication and monitoring would be put in place. Gambusia fish and buckwheat fish can be used for this purpose. Larvicides, the currently used larvicide is temifos. Source reduction by environmental measures using minor engineering methods, clearing the margins of water bodies, de-weeding to ensure proper water flow, and filling of a small temporary water collections. Effective entomological surveillance is desired. Entomological surveillance will be carried out by the zonal entomologist. The entomological teams will survey for entomological parameters. The team will also assess the effectiveness of insecticide-treated bed nets and long-lasting. Implementation of legislative measures. Strict bylaws exist for prevention and control of mosquitogenic conditions in few states and towns. State governments would be encouraged to extend these bylaws to other towns and cities and implement them effectively. The third component, that is the broad activities, is supportive interventions, and the most important is behavioral change communication. Establishing information education communication, behavioral change communication cell at Directorate of National Vector-Borne Disease is a significant development. Development of a strategy-specific prototype materials and healthy public policy by hiring an agency. IC BCC activities through print and electronic media at national, state and regional level. Strengthening of IC BCC activities at grassroots level. Special campaigns during spray distribution of nets and anti-malaria month during an anti-malaria month. Strengthening of services delivered to the vulnerable community and for marginalized sectors. Public-private partnership and intersectoral convergence. Improving outreach services through partnership with NGOs and other Panchayat Raj institutions. Implementation of the schemes, 6 public schemes initiated for public-private partnership schemes for National Vector-Borne Disease Control Program. Flagging the issue of intersectoral convergence. Flagging the issue of intersectoral convergence through Planning Commission. Niti Aayog, which has been changed to Niti Aayog. State level annual intersectoral meeting and district level quarterly meeting for sensitization. So intersectoral convergence, community participation, these are the key issues. Human resource development through capacity building, providing additional human resource wherever required. emphasizing that states fill up required positions at various levels, continuation of performance-based incentives to the program personnel including ASAs, that is accredited social health activists, and village-level volunteers. Capacity building of trainers by involving medical colleges and apex institutions. National Institute of Health and Family Welfare, situated in New Delhi, for providing on-job training for personal reorientation for existing program. Operational research, including studies on drug resistance and insectivicity susceptibility, is desired because drug resistance vector and as well as drug resistance both are becoming a very significant problem in malaria control. Operational research would be undertaken with the help of National Institute of Medical Research to monitor drug resistance, pharmacological vigilance, quality assurance, and insecticide resistance. Studies on vector bionomics and changes in their biting and resisting behavior is required because accordingly the strategy has to be modified. Research will also be conducted for development of new tools and methods for vector control. Logistic management in pharmaceutical system is a very critical input because unless logistics are supplied in time, program cannot run smoothly. Procurement division of National Vector and Borne Disease Control Program would be strengthened by recruiting a regular procurement specialist officer of joint director level, supported by consultants. Supply chain monitoring would be done through a hard agency to ensure the availability of commodities up to the primary health center level. The existing National Anti-Malaria Management Information System would be made fully functional by replacing all old computers and providing internet facility at district level. Communication support would be provided, integration of reporting of core indicators with NRHM and HIMS, establishing sentinel surveillance sites at districts and prominent hospitals to monitor the trends of the disease, morbidity as well as mortality. Periodic review at all levels and program evaluation at periodic intervals. Positioning of consultants at national, state and district levels. Vector-borne disease technical supervisors at block level and data managers at district level. Use of quality assurance methods, sub-district level for monitoring and implementation of program. Periodic population-based activities and community-based surveys will be undertaken. Remote sensing. In vector-borne disease control, remote sensing technology is a tool that can pay dividends, surveillance of habitat, densities of vector species, prediction of incidence of disease that must be considered as a new intervention in epidemiology of malaria and vector-borne diseases. Then, after discussing the broadest strategies, we would like to have a glimpse of urban malaria scheme, which was launched in the year 1970 in urban areas as a centrally sponsored program. Initially only in 23 towns, but now 133 towns and cities in 19 states and union territories are covered under the scheme. The malaria incidence in urban areas went up manyfold because of urbanization, construction, industrialization, and many processes. And vectors like Anopheles stephensi, supplemented by Anopheles species, had been responsible for urban malaria. They breed in wells, cisterns, then water bodies, and wet cultivations. Objectives of urban malaria scheme has been to control malaria by reducing the vector population in urban areas, reduce morbidity and mortality through early case detection and prompt treatment, popularly known as EDPT. Norms for establishment of urban malaria scheme: the town should have a minimum population of 50,000. API should be 2 or above. Town should be promoted and strictly implement the civic bylaws and eliminate domestic and other types of breeding places for mosquitoes of malaria. Early diagnosis and prompt treatment to patients through passive surveillance institutions such as hospitals, dispensaries, and malaria clinics. Recurrent anti-larval measures through conventional larvicides in towns. Minor engineering methods like source reduction, sterilization, deweeding. Biological control using larvivorous fleas at appropriate breeding sites. IC campaigns for community awareness and their involvement. Aerosol spray with pyrethrum extracts in 50 houses and around malaria patient positive case has occurred, and to kill infective mosquitoes. Organization set up for urban malaria scheme at town level. Biologist is the overall in charge for the implementation of the scheme. At state level, additional director malaria and malaria, or joint director malaria and malaria, or deputy director malaria and malaria are responsible. And at central level, we have Directorate National Vector-Borne Disease Control Program. Now coming to the last objective that has been said, just to have an overview of national drug policy and malaria. The National Drug Policy on Malaria was first formulated in the year 1982 and has subsequently been reviewed and revised periodically. The present National Drug Policy for Malaria came in the year 2010. Early diagnosis and complete treatment is one of the key strategies of the National Malaria Control Program. And therefore, all fever cases clinically suspect of malaria should be investigated for confirmation of malaria either by microscopy or by rapid diagnostic test. The preventive component has to be greatly eliminated. The aim of the policy has been providing complete care. By the term complete care, we mean clinical as well as parasitological care of malaria cases. Second, prevention of progression of uncompleted malaria into severe malaria and thereby reduce malaria mortality. Third, prevention of relapses by administration of radical treatment. Fourth, interruption of transmission of malaria by use of dermatocidal drugs like primapine, and preventing development of drug resistance by rational treatment of malaria cases. The policy has therefore clearly addressed many facets which are important for effective malaria control. Drug schedule for treatment of malaria under National Vector-Borne Disease Control Program. Treatment of vivax cases. Diagnosis of Plasmodium vivax malaria may be made by use of rapid diagnostic test, bivalent or microscopic examination of the blood smear. On confirmation, following treatment is to be given. Chloroquine 25 mg per kg body weight divided over 3 days, 10 mg per kg body weight on first day, 10 mg per kg on second day, and 5 mg per kg on third day. And primapine to be given in the dose of 0.25 mg per kg body weight for 14 days. Age-wise doses for chloroquine for Plasmodium vivax is children less than 1 year. Day 1, day 2, day 3 doses are 10 mg per kg body weight, 10 mg on first day, 10 mg per kg body weight on second day, and 5 mg per kg body weight on third day. In terms of tablets, if we convert, then less than 1 year, half tablet on first day, half tablet second day, 1/4 tablet on third day. 1 to 4 year, 1 tablet, and half tablet on day 1, day 2, and day 3 respectively. 5 to 8 years, 2 tablets, and 1 tablet on third day. 9 to 14 years, 3 tablets on day 1, 3 tablets on day 2, and 1.5 tablets on day 3. In 15 years and above, 4 tablets on day 1, 4 tablets on day 2, and 2 tablets on day 3. Primapine for Plasmodium vivax, daily doses for 14 days. Children less than 1 year, primapine is not given. 1 to 4 year, 2.5 mg base tablet. Number of tablets to be given is 1. 5 to 8 years, 5 mg base is given. Number of tablets 2. 9 to 14 years, 10 mg number of tablets to be given 4, and 15 years above 6 tablets. The entire dose is for 14 days, and primapine is not given during pregnancy and also in infants suffering from glucose 6-phosphate dehydrogenase deficiencies. Treatment of uncomplicated falciparum cases in other states other than northeastern regions. Artemisinin-based combination therapy, ASTs, along with sulfadoxine, paramethamine combination. Artesunate, available as 50 mg tablets are given. AS, artesunate is normally abbreviated as AS. Available as 50 mg tablets are given for 3 days. And sulfadoxine, paramethamine, SP tablets containing 500 mg sulfadoxine and 25 mg parathramine are given per day for 1 day. All tablets for a day should be taken together, swallowed with water. Let's see, primapine PQ large tablet should be given on second day. ACT is not to be given in the first trimester of pregnancy. With the introduction of different color blister packs for different age groups, treatment by field level staff has become very easy. The color code for different age groups for packaging of ACT, SP has been depicted in this chart. Pink blister, day 1 ASSP, day 2 ASPQ, and third day AS only. So color codes have been given for age groups. Pink blister 0 to 1 year, 1 to 4 year yellow blister, 5 to 8 year green blister, and 9 to 14 year red blister, and 15 to ever white blister. Packages are given, and that has simplified the approach that by seeing the color of the pack, the person and looking at the age of the person, the worker will be able to give the specific treatment. Similarly, ACT and artemether or lumefantrine combination, which is not recommended during the first trimester of pregnancy and for children weighing less than 5 kg. Combination has been devised, and co-formulated tablets of ACT and L are available. The color codes are different, and color codes have been given depending on the same age group. But here the one extra component, which besides age, the weight of the child is also taken into account. But at many places, if the weight is not present, we can go by these criteria. So these guidelines are already evolved for northeastern region, where we are artemether and lumefantrine are also added. The packaging size for different age group based on kg body weight, average kg body weight, and having discussed this, that the strategies are different from northeastern region and other states. Color code packages have been evolved, which help us in finding out this. Treatment of uncomplicated plasmodium falciparum cases in pregnancy, first trimester, quinine salt 10 mg per kg, 3 times daily for 7 days. One has to note that quinine may induce hypoglycemia. Pregnant women should not start taking quinine on the empty stomach. They should eat regularly while on quinine treatment. Second and third trimester, area-specific ACT as per dosage schedule given above. ACT-AL in northeastern region, ACT-SP in other states. Primaquine prevents transmission of falciparum malaria to others by ability to kill gametocytes. So therefore, it should not be given on empty stomach. Children less than 1 year and pregnant women should not be given primaquine. Treatment of mixed infections, Plasmodium vivax and Plasmodium cases. All mixed infections should be treated with full course of ACT and primaquine 0.25 mg per kg body weight daily for 14 days. So mixed infections, we have to guide for primaquine, we follow the guidelines given for Plasmodium vivax. Treatment of severe malaria cases. Severe malaria is an emergency. Treatment should be given as per severity and associated complications, which can best be decided by treatment physician. The guidelines for specific anti-malaria therapy are as follow: artesunate 2.4 mg per kg body weight. The guidelines for specific anti-malaria therapy are as follow: artesunate 2.4 mg per kg body weight, IV or IM given on admission, then at 12th hour, then 24th hour, and then once a day. Or artemether 3.2 mg per kg body weight IM given on admission, and then 1.6 mg per kg body weight per day. Or artemether 150 mg IM daily for 3 days in adults, only not recommended for children. Quinine 20 mg per kg body weight on admission, IV infusion or divided IM injections followed by maintenance dose of 10 mg per kg body weight. But one has to, loading dose of quinine is 20 mg, and one has to take care that it may lead to that quinine if the clinician feels inappropriate, and it may lead to hypoglycemia. The parenteral treatment in severe malaria cases should be given for minimum of 24 hours once started, and then ability to tolerate oral medicine, we can switch over. After parenteral artemisinin therapy, patients will receive a full course of oral ACT for 3 days. Those patients who receive parenteral quinine therapy should receive oral quinine 10 mg per body weight 3 times a day for 7 days, including the day when parenteral quinine was administered, plus doxycycline 3 mg per kg body weight once a day, or mycin 10 milligram per kg body weight 12 hourly for 7 days. Doxycycline is contradicting in pregnant women and children under 8 years of age. ACT as described can be given, or we can give ACT combination as described earlier, or as we have discussed earlier. So in order to stop malaria, we have discussed various approaches, but certainly we have to take care that mosquito density has to be reduced. Because there are two approaches. One is that we have to reduce the reservoir. By that we mean the cases of malaria. If the cases of malaria are not there, even the presence of mosquito will not make a difference. So reservoir has to be reduced by prompt treatment, and we have to also bring down the density of the mosquito to a very low level by using integrated approaches, and which includes environmental manipulation, which includes various types of use of various types of insecticides, which depends on biological control, and also there are other approaches like genetic incompatibility and others that can be tried. So, just we have discussed that the journey of national malaria control program from the year 1953, when there were 75 million cases per year, and now the case load in 2014-15 had been around 1.some million cases. But we have to have very concerted efforts, because there are many paradigm shifts in malaria: desert malaria, tribal malaria, northeastern malaria, forest malaria. So many things have come out. Then another problem is drug resistance and other things. Necessary programmatic strategies have been evolved. It is hoped that concerted efforts of every stakeholders will be able to take care of malaria problem now. Thank you very much for visiting EPG Pathshala.